Feels like it's been a minute since we've done this.
Yeah.
While we are waiting for everyone else to join us, please put your name and agency or hospital in the chat so we can track attendance. All right, I'm going to continue to admit folks as they come in, but I'm going to turn it over to Carrie and Tara to go ahead and get us started. Welcome everyone to June Learning Forum.
And I almost said good morning until I realized that it's officially noon. So good afternoon, everyone. Thank you guys so much for taking time out of your very busy days. I am not naive to the fact that it is summertime in the birthing world, which means that in many, many, many facilities, it's insanely busy with people taking time off, onboarding new grads, babies galore. So thank you so much for taking time off. I want to kind of go through just some quick reminders that we wanted to share everyone. If you haven't seen this yet, I know we sent this out and you'll get it again when we send out the slides from today. If you haven't had a chance to register for the Maternal Mortality Prevention Conference, that's coming up in Kansas City at Sporting Park on July 29th and 30th. So the link to that will be in what we send out from today's learning forum. Next slide, please. On our May 1st in-person conference, we launched our post-birth, A1's post-birth warning sign bracelets to our enrolled facilities. Those of you that came in person received boxes of those at the time, and we are in the process of shipping out to the rest of our facilities. But we wanted to make sure that everyone had the link to access the implementation toolkit. And just a reminder, it is one more tool that's supposed to go alongside the post-birth discharge information, the magnets, all of the information that we're trying to get out there to be proactive to alerting our birthing persons in Kansas. Next slide, please. I wanted to give an update. This was a hot topic for a while and it's kind of subsided, but I think the important thing is that effective June 21st, all 42 people that were potentially exposed to the hantavirus aboard the cruise ship that was in the Atlantic have all finished their 42-day monitoring period. And we're going to celebrate that no cases of the disease occurred in the US as a result of this outbreak. So celebration for that moment there. Next slide, please. Tara, I'm going to turn this over to you.
We always just high five each other at this moment and talk about really the short and long range implications of all the work that you're doing. And I love that Carrie called it busy birthing season. And my farm brain went to, of course, calving season, and I can't get off of it. So, long story short, Western, Eastern, North and South Kansas, you're all working hard on initiatives related to this work. And we like to show you the red hearts represent birthing hospitals across our state that are enrolled in this safety bundle. The blue are non-birthing facilities. And we know that there are many of you who are not represented on this map, but I see names I recognize that are doing important agency level work, community health worker work. The list goes on, breastfeeding work. And so, yeah, yes, we are impacting at least 83% of all births, but we know that's an underrepresentation of the work and the extension of the work that's happening across our state. Next slide for me, Tiffany. And this is the model of care that as we get started on today's topic here in a little bit, and we talk about how does all this connect and it feels overwhelming almost when you look at a slide like this, but this is actually what's happening now. So when we started out with fourth trimester work and immediate postpartum discharge handoffs and, evaluating all the needs of every postpartum patient, now we've drilled down to specific needs of the severe hypertension disorder patient, both in the antepartum, intrapartum, and postpartum setting. And so this model is describing to everybody in the state, and we bring it up and we show it and we share it out and we put it on our website because you all are involved in some layer and some version of all of that work. We also know from Carrie and I, and certainly Michelle Black's work of data collection, that there's a lot of connections happening with the patient with severe hypertensive disorder upon discharge that is improved. Your timely treatment is improved. And we know then that you're handing her off because you continue the other work. If she has breastfeeding needs, pumping, hand expression, if she has insurance concerns, if she needs a home blood pressure cuff. So again, it's extensive, but it's working. Next slide. And this is just another visual model, kind of a little prettier, if you will. Certainly the patient, the pregnant patient is the best part of it, but it talks also in here about the transfer protocol. Kudos. Carrie, I might be still in your thunder here, but kudos to those who have sent us their transfer protocols. Those are actually hard to read because you're envisioning the moment that that has to be pulled out. And I certainly have been in those positions and been in the middle of a really couple of hard ones. I know you all have too, but it's vital that we tighten up the referral and transfer to tertiary care centers when a patient needs elevated care. The follow up, how she's followed up through that first year postpartum after she leaves. And treated appropriately is also part of our work. So again, this is that prettier version of all the things happening to improve maternal outcomes. One more thing, and then I'll turn it back over to Carrie. I want to remind everybody that once a year we get data from KDHE and some other sources, some important other sources in the state and nation. We're going to see the fruits of your labor, no pun intended, in this 2-year increment that continues. We're going to see that over a 5-year period. So know that even as we talk about this bundle starting to wind down, we're going to keep track of the data, hypertensive disorder response, et cetera, for years to come. And I'm excited to see that pendulum change thanks to your work. So high five, you guys. Back to Carrie.
Awesome. And Tara just pretty much teed us up for the gentle reminder that this bundle wraps up, you guys, the end of this year, wraps up the 2-year hard work and implementation of the severe hypertension bundle. Does that mean the work stops? So that's always what I mentally have to prepare myself for. Is the hope is absolutely not. The hope is what we've implemented throughout this work becomes embedded in everyone's processes and their facilities, and that we celebrate best practice and phenomenal outcomes that'll come as a result of this. So with that wrap up in December in mind, next slide, please. We wanted to give you a heads up that Michelle Black, our data coordinator, is going to be sending out the emails for the next round of data collection on July 1st. So for those of you enrolled, that data will be due back to us by August 1st, and it will be a Q1, Q2 data collection of 2026. So we've been able to look at what's happened as a result of this bundle over 2025, and now we're looking to see how much more progress has happened as we've continued that this year. And then just a reminder too, I see there's 23 names in the chat, but 35 people online. So if you guys could continue just putting your names and facilities in the chat as we do this, we would love to have a good depiction of who's joined us for today. Next slide, please. Okay, we announced in our May 1st meeting, but the next bundle that the KPQC will be rolling out in January 2027 is the obstetric hemorrhage bundle. We surveyed states all over Kansas, both birthing and non-birthing facilities, and it was heard loud and clear what the desire was for it to come back. Almost 70% of the hospitals who responded asked for the OB hemorrhage bundle to be implemented. Just a reminder that initial bundle was released by AIM in 2013, but they've actually updated that to a 2.0 within the last 5 years. So that is what we will make sure that we are rolling out to all of our facilities that enroll. So stay tuned, and that'll be what comes up next. Next slide. And tying those pieces together, I couldn't help in my nerdy reading that I do, you guys, but come across this article that did a phenomenal job of highlighting the impact of postpartum hemorrhage and what risk that places on our patients of cardiovascular disease. So if you haven't had a chance to read that article, the link to it will be, as you see on the title there on the left-hand side, in the PowerPoints that Tiffany sends out tomorrow. So I encourage you guys to read into that. It was an interesting read for me. I think you'll enjoy it too. Next slide. I'm excited today for our speaker. I think we spend a lot of time knowing that there's more work being done in the state besides just what the PQC is putting out. And sometimes that includes gathering all the people together so that we're not reinventing the wheel, so that we're collaborating, so that we are sharing resources and making sure that all the touch points are kind of mapped out so we all know what we're doing. Rachel Ray is the program manager for KDHE, our Kansas Department of Health and Environment, Division of Healthcare Finances, DMS funding for our Transforming Maternal Health Cooperative Grant. Just short for you, for those of you who don't know, we call that TMAW. So if you ever hear us rambling on about the different funding or different grants and work that's being done out there, this is the TMAW work. So Rachel comes to us with over 7 years of experience leading and supporting initiatives and technical assistance centers focused on maternal health, behavioral health, and suicide prevention education. Her work focuses on addressing behavioral health needs and the social and environmental factors that influence maternal health and well-being. She holds a graduate degree in public health and public affairs from the University of Missouri and is a certified health education specialist. She is definitely passionate about advancing collaborative, community-centered approaches that support women, children, and families, and we adore working with her. So I'm going to turn it over to Rachel, and she's going to give you guys a good overview and some details about exactly what's going on in Kansas with that transforming maternal health.
Yeah, thank you, Carrie, so much for having me and my team here today. So Transforming Maternal Health, as we call it, TMA, that is a CMS-funded Medicaid initiative to improve outcomes for maternal and child populations. And if you want to go to the next slide, please. And so the TMA grant is a 10-year grant. And we are about 2.5 years in. And so we thought that this would be a good opportunity to provide an update on what we're doing and what is still to come before we enter the official implementation period in January of 2028. Next slide, please. So one thing that's kind of unique about the TMA model is that it does have a test and a comparison region. So this model will only be implemented in the southern half of Kansas, essentially just right down the middle, though we are excluding Sedgwick County, Shawnee, Douglas, Johnson, and Wyandotte counties from both the test and comparison. And the reason for that is because the TMA model is trying to maintain a rural and frontier focus. So over the next 10 years, we will be evaluating the outcomes of the interventions that the TMA model is supporting in the test region and how that stacks up against the comparison region. And next slide, please. So there are 5 key model goals that were outlined for the TMA program by CMS. So overall, we are working to reduce the rates of low-risk C-sections, reduce the incidence of severe maternal morbidity, reduce the rates of low birth weight infants, improve the overall experience of care for perinatal beneficiaries, and lower Medicaid and CHIP expenditures. And next slide, please. So in order to accomplish those key goals, there are a lot of stakeholders that we need to be interacting with. So we are working closely with both our internal teams at KDHE, including the Division of Healthcare Finance and Public Health, other agencies such as KDAS and Department of Children and Families. We're of course working with our MCOs who will be invaluable in implementing TMA. And then it's also very important for us to communicate with providers, statewide maternal health organizations, and community-based organizations. So right now we've kind of been in a phase of information gathering, seeing what is currently happening in the state of Kansas, what are current initiatives that the state is working on, that the communities are supporting, and then also talking to providers, and that includes community health workers, doulas, midwives, and physicians. And so I'll also kind of throw out a note here that if you are interested in sharing your experiences with the TMA team, we would love to hear from you. We want to make sure that we're hearing from the people that are out there working on the front lines about the challenges and the barriers that they're experiencing working in the maternal health field and some of the struggles that their patients may be facing as well. So at the end of this presentation, we will have the TMA contact information, and you're more than welcome to reach out to us, and we'd be happy to hear from you. And next slide. Is Tiffany still there?
I think she may have a glitch. Hold on one second, see if I can
Oh.
advance it for you. Bear with me. Okay, Tara, do you have access to, she made us both administrators, but it's not allowing me to move anything forward.
I have the same problem and it just completely shut me down. Like I literally had to log all the way back off and on. So something must be going on. I apologize, everybody.
Nope, it's okay. You guys bear with us as we work through our tech troubleshooting right now. I think hopefully Tiffany can log off, and I'm shooting her a text right now.
I do have, I could try and share my slides if that would
Yeah,
help.
I would do that. And Rachel, I just keep rolling.
Yeah.
I love what you're saying, and your words are actually more important. I know your slides are amazing, but we can send those out at the front, at the back end too. So I'd keep going.
Yeah.
Perfect. Hopefully it'll let you just take over. There we go.
Okay.
Beautiful.
All right. And I couldn't figure out how to get my screen set up properly. So
That's
as long as
okay.
you're seeing the slides, that's fine. So these are some of the three key pillars that the work of the TMA model is centered around. So we have the access, infrastructure, and workforce, which is pretty much just what it sounds like. The TMA model is working to increase access to midwives, doulas, perinatal community health workers, birth centers, and then we also have a lot of work dedicated to improving the infrastructure that is surrounding both Medicaid, MCOs, and healthcare providers, as well as developing and implementing a payment model. We have also elected to look into the possibility of certifying professional midwives or certified midwives, and are looking into the possibility of a reimbursement pathway through Medicaid, all in part of trying to increase access to midwives. And then the quality improvement and safety pillar, that is focused around really working with the KPQC to see what they are currently doing and how we can support them. So I do have another slide that I'll share in a minute that kind of highlights what exactly we're doing with the KPQC. And then, of course, we have whole person care delivery, and that is focused on increasing home monitoring, home visits, mobile health, and telehealth, and then also increasing risk assessments, screenings, and referrals for perinatal mental health, substance use disorder, and health-related social needs. Of course, because we know that behavioral health conditions are leading causes of maternal mortality, especially in Kansas. So that is a focus of ours, and we're working closely with the KPQC and taking the findings from the Kansas Maternal Mortality Review Committee reports and being sure that we're integrating those into our initiatives. And this is just a very brief kind of high-level overview of all of the different little things that are going on related to the access and workforce pillar. I didn't even include the data infrastructure or value-based payment because that's just a whole nother wheelhouse that would take forever to explain, but we will have more information about that on our website in the coming months. And so in order to increase access to midwifery workforce, we are looking at working with some technical colleges throughout Kansas to develop training pathways. And that's actually not only for midwifery, but also for doulas and perinatal community health workers. We are currently in process. This is something that was already being worked on, and we kind of tagged on to add midwives to this, but there is an interprofessional consultation billing pathway policy that is going through the legislative review process right now, and that will allow providers to be reimbursed for their times spent consulting with providers on a care plan for a patient. So especially when you're talking about maternal care, that could mean that a midwife is able to work in consultation with an OB or a maternal fetal medicine specialist without necessarily having to elevate that individual's care to the OB or MFM. For doulas, we are currently looking at options for streamlining authorization. Right now, for individuals who are on Medicaid, they have to receive, it's kind of like a signed referral. There's a number of providers who can sign that referral, but it is still a barrier that's in place for those patients to be able to access doula services. We know that doula services are associated with improved outcomes for mothers, and so we are looking at ways that we can reduce that barrier. We have also heard from doulas that there has been some difficulties with the billing process, both on their side and the side of the MCOs. So we are looking at several different options to make that billing process easier for doulas. And then we've also been trying to talk with birth center owners throughout the state on the struggles that they have had in operationalizing their birth centers. We know that there was recently a birth center in the Kansas City area that was, I believe, the only birth center in Kansas accepting Medicaid patients, and they had closed down because it was not sustainable. And so we are evaluating what about the current system makes birth centers unsustainable and what can be done to increase the sustainability for birth centers. And then for perinatal community health workers, which is not currently a thing, but we are looking at making it a thing because we know that community health workers in all of the various forms that they may come in are invaluable to the care of maternal populations. And so we are exploring the possibility of developing a perinatal community health worker kind of micro credential or certification that would allow a community health worker to become more knowledgeable about the common causes of maternal mortality in ways that they can help maternal patients kind of navigate through the system. And then, of course, all of this kind of across the line, we're also working on doing a payment analysis to analyze whether the costs associated with providers providing services is in line with the reimbursement that they receive. And I am also very interested in the possibility of expanding the Kansas home visiting programs. I had actually never seen that slide that Tara shared about the kind of Kansas hypertension model. And I was excited to see that that included home visiting as well, because that is, I think right now, kind of an underrated option for maternal populations that can dramatically improve outcomes. So I was excited to see that, and I'm excited to talk with the KPQC further about home visiting. And then on the next slide, I just have not a super pretty slide because we are kind of in the trenches of figuring out how we're going to work together, but some of our milestones related to working with the KPQC. So of course, we have established that relationship and are working closely to see where we have options for intersection and collaboration with all of the TEMA milestones and the KPQC initiatives. And then we also plan to work together to design an implementation plan to build capacity for participating in AIM patient safety bundles. And this is both on behalf of the KPQC and on behalf of the sites across the state, well, for TEMA primarily in the test region, that are participating in these bundles. We've had a lot of conversations about the difficulties surrounding needing to collect data and report data. And we feel strongly that there has to be an easier way to do that, to make that more feasible for our OB champions. And so that is something that we'll be looking at as we develop our relationship and move further along in the TEMA process. And then we are also working to expand the database in which that data is currently collected and analyzed. So more information to come kind of on this pillar in the future, but looking forward to what we can accomplish to hopefully make the work of the KPQC and all of the OB champions a little bit more feasible. And then for whole person care delivery, this is really about making a more seamless experience for the patient. Right now, we know that screening, whether that be depression, anxiety, substance use, or health-related social needs, is not really done at any consistent frequency or with any consistent tools all across the state. So all providers have different workflows that they follow, and that results in inconsistent care for the patient. So TMA is working on developing a toolkit of recommended screening tools, workflows, and educational materials for patients and providers. We know that the public health team at KDHE currently has recommendations posted on their website, and we are working closely with them to ensure that we'll essentially be adopting the same updated recommendations. We are also looking at providing training opportunities for hospitals and provider staff on these selected behavioral health screening tools. And I think most importantly, one of the TMA milestones is establishing a bidirectional referral pathway. And that's also called a closed loop referral system. So that will allow providers to receive updates from the receiving referral provider on whether that patient has been able to access the services or if they may need to be referred to a different service or location. And then also for home monitoring, we are looking at expanding coverage to maternity patients within the Medicaid at the Medicaid level. We want to be sure that we're supporting ongoing blood pressure cuff projects. I know that there was the KPQC has recently been doing a cuff project, and I think there's another community-based organization in the state working on one as well. So we want to be sure that we are coming in and supporting those projects, not duplicating any efforts, and seeing what we can do to make blood pressure cuffs more accessible for Medicaid patients. And then just in general, looking to expand behavioral health supports for rural maternal populations and several potential initiatives aligned with that. One of which that I am really passionate about is expanding priority access at certified community behavioral health clinics for maternal populations. Right now, priority populations at CCBHCs are eligible for same-day assessment. But that doesn't automatically mean that they receive same-day treatment or timely treatment for whatever behavioral health issue that they may be experiencing. And of course, we know that when we're screening, we need to be able to refer patients to getting the treatment that they need. So that is something that we are working with our partners with at KDHE and community-based organizations as well to make sure that we can get a process there that doesn't leave providers feeling like they don't know where to send their patients and ensuring that patients are getting the care that they need. And then along with the whole person care delivery. So this has been kind of a big focus of the work I have been doing with TMOM in the last many months. As part of our kind of toolkit for behavioral health is we have developed a preliminary, where we're open to feedback, screening frequency for behavioral health and health-related social needs. And so this includes doing an initial intake screen for depression, anxiety, bipolar disorder, and PTSD. Bipolar disorder and PTSD don't generally need to be screened for more than once a year at most. So subsequent mental health screens will just be for depression and anxiety. The American Academy of Pediatrics recommends screening at the well child checks through at 1, 2, 4, and 6 months. We have decided to adopt postpartum support international recommendations and also recommend screenings at the 9 to 12 month appointments for the child, because we know that there is a clinically significant number of women who do not get diagnosed with postpartum depression until after that 6-month mark. And so this is another touch point for those women to be able to express any difficulties that they may be having. And then for substance use, we had recommended that there is an initial screen at the prenatal intake appointment, a second SED screening in the 3rd trimester. And at that point, they may have developed a better rapport with their provider and may be more open to sharing any struggles that they're having. And then, of course, a postpartum screen. And then for health-related social needs, that initial screen at the prenatal intake, and a postpartum screen. And there's also a MCO-led care coordination process. And so we have spent a lot of time focusing on ways that we can improve that and improve both beneficiary and provider collaboration with the MCO-led care coordination. So also more information to come on that. There's still a lot in development with TMA. But that will be really cornerstone to making this process work, is ensuring that providers and that MCO-led care coordination are working together effectively and efficiently to make sure that the patient is accessing the services that they need. And then as far as the specific tools that we have selected, as it notes, these have been developed in partnership with the KDHE policy and public health staff, and these selections will be refined pending further discussion with providers. Also super happy to hear any input that you guys may have in attendance. And as I said, you're always welcome to reach out to us. But for depression and anxiety, we have chosen to use the Edinburgh Postpartum Depression Scale. We know that is widely used in Kansas today. It is highly effective. It works in most EMRs. And for bipolar, the Composite International Diagnostic Review, it does have higher specificity and sensitivity than the broadly used MDQ. I believe it's also only 2 questions, so pretty feasible for providers to use. For health-related social needs, there are a lot of community-based organizations and even state agency departments that are currently using the American Academy of Family Physicians social needs screening tools. We are aware that FQHCs use the Prepare tool, and we are certainly not looking to change what has been working well for them. I will note here, though, that there is limited research on the effectiveness of health-related social needs screening tools. They're not clinically validated. So the really important thing that we're trying to get across here is that we recommend that every provider is screening, because we know that non-clinical drivers of health are very significant drivers of health. And I will just pause there really quick. I know I've been talking a lot and I can't see the chat. So Heidi, Allison, Tara, any questions in the chat that I should address? Okay. And then just moving forward a little bit about what providers will really benefit from participating in TMA. So I think one of the most important things about TMA is that it is voluntary. Providers are not required to participate in the TMA model. And so what we are working on right now is really working on developing a recruitment toolkit that will highlight all of the benefits that providers have or will receive by working in collaboration with TMA. So that would include targeted support for value-based care models. We know that that is the way that insurance, especially state Medicaid agencies, are moving to, is value-based payment. And so we like to think of the TMA model as a way that we can help providers kind of work through what a value-based payment model looks like. And then, of course, with the value-based payment model, there is a potential for shared savings. So providers can benefit from those shared savings. And the TMA model does also have provider infrastructure funds that are designed to support providers in making any necessary data infrastructure or process changes that are needed to support the TMA model. We also are able to provide technical assistance, coaching, and learning collaboratives to help with the implementation of evidence-based maternal health interventions. And of course, it's a direct route to provide feedback on the TMA model and the efficacy of the proposed interventions. And then in addition to that, we have enhanced care coordination infrastructure that we are working on implementing, access to those expanded care teams that we have talked about, training on perinatal behavioral health and health-related social needs, tools for managing high-risk pregnancies, and overall, the thing that we are most passionate about and looking to improve is the patient outcomes and experiences. And to be an eligible provider for TMA, providers have to be a legal entity, provide the full range of perinatal care, and of course, comply with applicable model requirements as they may come about. And this is just our contact information and our website. I'll put that website in the chat. We will be working on developing a listserv in the near future so that we can share updates on the TMA model. And then I'll also put our email in the chat as well. Okay, and I know I just threw so much information out there. And it feels like I didn't even cover the half of TMA because it is just such a big grant and there are so many little pieces. So we've got 10, 15 minutes left, and I just have the floor open for questions. I've also got my project director, Heidi, here, and my colleague, Allison, who's kind of the lead on the value-based payment and data infrastructure. So we're open to any questions you may have about the TMA model.
Hey, Rachel, I'm going to jump in. Great job. Thank you. I think the cross-sectional work that is happening across the state is almost overwhelming to hear, in a good way, right? We're all doing important work, so thank you very much. I think there's probably some folks on the webinar today that are asking themselves, well, how does this connect to my work, especially if I'm not in that specific region? Your work is directly worked, woo, more Mountain Dew, please, is directly related to this work because you are doing things like the Cuff Project and sustainability pieces for breastfeeding models. You are increasing access to care. You are making sure your transfer policy is correct. We are timely treating blood pressures no matter where the patient shows up. So remember what Rachel's work is doing. And Heidi's work and everybody else on the call. Allison, good to see you again, by the way. All of these folks across Kansas are working to standardize the process. And I think sometimes we get so caught up in the bedside work and talking to a patient in the bathroom about a concern that she has about intimate partner violence at her home, and we forget that that moment is based on this work. And I applaud all of you because we're trying so hard. Um, I also want to say out loud, I think that one of the things that's been questioned across the state is, are you all talking to each other? There seems to be 17,000 maternal health initiatives, an equally amount of perinatal and meaning, you know, the pieces of that are related to just access and insurance, and certainly on the newborn side. And the answer is yes, we are. At least we're trying really hard. How many meetings can you fit into a day, right, guys? But the reason that we wanted you all to hear this is because while we talk about licensure, and why we talk about regionalization of care, we're talking about all options for birth. We're talking about wherever we meet her, wherever she is, and they are. And then we talk about how to make sure that the outcome changes. So don't get caught up in the specificity of the players being not you or not them or not it. It is about the connection to care. And quite frankly, you guys, we have a major access problem in Kansas, and it's impacting outcomes in ways that I'm not sure we can explain well, but we see it and you hear it. So that's enough. I just wanted to make sure it made sense to you why we invited Rachel, why we have the TMA team as part of the greater work happening. And if you have questions about some of the things that are happening within TMA or other places, please reach out. But also know your work is part of this work.
Yeah.
Rachel, did I say
Tara,
that okay? It makes sense?
yeah, that was great. I appreciate that addition there. And I want to add too that, if, of course, the hope is that the TMA model and the interventions are wildly successful and that all of this becomes standardized across the state. The TMA model, though, is also focused on sustainability. So not just developing a program with some funding that's going to end in a few years, but actually changing policy at the state level to create lasting and sustainable change. So it is a 10-year model, and so we have a lot of time to get all of that done. And our hope is that by the time the TMA model officially ends, The interventions that we have implemented will be proven effective, and if not, maybe those interventions change, but they will stay with the state, and those outcomes will remain improved even when CMS funding ends.
Thank you, Rachel. Any questions from you all? Otherwise, we'll give you some time back. We look forward to talking to you. Actually, uh, no, not in a month, whenever you need us. Carrie and I are at your disposal, if that's the way we describe that, and happy to help and certainly make connections if there are some needs. Reach out to us with anything you need, guys, and we look forward to seeing you soon. Have a great day.